All right. So here's our next lecture, the heart. In lab, we've gone over the anatomy of the heart, so I'll sort of breeze through some of that part and really focus more truly on the physiology. But again, understanding the heart anatomy is going to help you understand the physiology component and sort of how it works. So this is the second of three parts of the cardiovascular system. We did the blood already. We're doing the heart today. And then next will be the vessels and sort of the transport. So the heart is essentially your pump, right? It's pumping the blood throughout the body, not only to get oxygenated blood to your tissues, but also to get it back to the lungs where it can reacquire new oxygen and give off CO2. So we talked about this in lab, so I'll move through these, but those are the pulmonary circuit and the systemic circuit. We talked about the different types of blood vessels, and the capillaries or exchange vessels. So you want to make sure you review the pulmonary circuit and sort of understand what we mean by pulmonary arteries and veins and systemic arteries and veins from that standpoint. So in terms of the anatomy of the heart, you guys know there are four chambers. We have the two atria, right and left, and two ventricles, right and left. And basically, the right atrium and right ventricle are taking deoxygenated blood that's coming from the body, from the systemic circuit, and pumping it to the lungs via the right ventricle, where it can reacquire oxygen, will re-enter the heart. Oxygenated blood will re-enter at the left atrium, and then move on to the left ventricle, where it will then be pumped back out to the body, so the oxygenated blood can then be acquired by all of our tissues in our body. Okay? So the anatomy stuff, again, we sort of went over this in lab, so I'm going to move through this really quickly. But as you can see, the heart is situated in the lungs, in between the lungs, and has its major components inside that thoracic cavity in terms of its structures. The pericardium, if you recall, is a double lining. We have a lining that covers the actual organ itself, the heart. Then you have a lining that covers the pericardium, the actual cavity, pericardial cavity. So it's this double lining. We talked about that in ANP1. It's simple squamous epithelium. The pericardial cavity is in between those parietal and visceral layers, and that's where we have this pericardial fluid that helps surround and stabilize the heart. And so here you can sort of see that if you look at this image, right? You can see sort of closely there. I'm going to try to change this color here. Let's see if I can do that. Do more of a red should help, right? So in terms of the color of the heart, you can see, there we go. You can see the inner lining, and then there's a cavity, and then the outer lining, right, in terms of how that's organized. The pericardial cavity and the different linings covering the organ as well as the cavity. And this gives a nice shot also sort of showing that lining. And so that lining is very significant in terms of having a lining covering the organ as well as the cavity, and this is the fluid-filled sac as they show in this arm. So that's kind of review from ANP1. So in terms of superficial anatomy of the heart, obviously we have these atria, right and left atria, which are smaller, they're thinner, right, and they have an expandable outer auricle, as we talked about in the lab, that can allow for the filling and the chambers to get larger as blood fills into these components. But the walls are thinner, right? The muscle, it's a different type of muscle, it's pectinate muscle, that actually pumps blood down to the ventricle. So it's not traveling as far, so you don't need quite as powerful of a muscle. The coronary sulcus is going to divide the atria and the ventricles, and the anterior interventricular and posterior interventricular sulcus will separate the left and right ventricles. So you can see that in these images here, right? So here is the coronary sulcus here, right? And then here is the anterior interventricular sulcus from that standpoint. This is an actual image of the heart You can see the right ventricle over here, left ventricle over there. Of course, here is the interventricular sulcus. Here's the auricle. See how that kind of looks like almost a cauliflower ear? That's on the outside, right? The superficial structure, the atrium, the chamber, is on the inside. And here's a nice posterior view where you can see some of those structures as well. All right, so the heart wall has three components. It has what's called an epicardium, which is the outer layer of myocardium, and then the innermost layer is the endocardium. The epicardium is, again, just that visceral covering, that outer layer that actually covers the heart. It's like a lining, basically, very thin, simple squamous epithelium. The myocardium, or the middle layer, is the muscle. That's where the thick muscle is located. It's concentric layers of cardiac muscle, and is divided into two ventricles, of course, and so that's what we'll be looking at. You'll be able to see that if we do the dissection, you'll be able to see that structure as well. And then the endocardium is a very thin layer on the innermost surface. And so you can see here is the nice, thick cardiac muscle tissue, myocardium. And this is what produces all the contractions. You can also see this thin inner wall here, and then this outer wall here, and then you have a nice thin space there in terms of the pericardial cavity. All right, so make sure to review those structures and just have a good idea of how those work. The cardiac muscle is, again, formed sort of in this concentric fashion, which gives it greater contractility. The muscle tissue itself, just sort of a review from A&P1, has these intercalated discs, right, which sort of link adjacent cardiac muscle cells, which help with movement of action potentials, but also can convey the force of contraction completely and keep things flowing properly. So if you look at this image, you can see there are striations, of course, much like we saw in skeletal muscle, but you can also see many nuclei, mitochondria, of course, and then these intercalated discs, which are going to be linking these adjacent sections. You can see one over here, and you can see one over in this section, right? So it's going to be connecting those components. And here's a sort of a close-up of that intercalated disc, right, in terms of how it links. But you can also see how the striations would be, and the organization of the thick and thin filaments. All that should be pretty familiar to you from our A&P1 discussion. And here is a nice histological image, which again we did back early on in A&P1, where you can see those intercalated discs. You can also make out the striations, I think, pretty well. Nuclei, of course, is here in terms of how this cardiac muscle tissue is organized. Now, some things we're seeing with cardiac muscle tissue, the muscle cells themselves are pretty small. Each is going to have a single central nucleus instead of being multinucleate like we'd seen previously with skeletal muscle. Also, it has these intercalated discs, which is going to be very significant in terms of its functionality. And so this is a nice chart if you want to review sort of comparing cardiac muscle with skeletal muscle in terms of, the contraction, how they're organized. The contractile proteins are very similar to myofibrils and other mitochondria and other components that we see of the heart. So this would be a good chart to sort of review the features, back really more what we talked about in A&P1. Now, if you slice open the heart, the internal portion, again, you're going to see a couple of locations where the divisions occur, the septum, right, the interventricular septum and interatrial septum, of course, are going to divide those components. So if you go to this slide here, you can see there's the interventricular septum, and then the interatrial septum is going to be in this location here, of course. We go back, some of the other structures, we really talked about a lot of these. Make sure you understand what an AV valve is, how it connects the atria to the ventricle, hence the term atrioventricle. Again, they're valves. They really try to prevent backflow. So they permit blood flow in one direction, going from the atrial to the ventricle so that blood doesn't spill when the ventricle contracts back into the atria. So it's really a different sort of, or a preventative component to try to keep things in line and the blood moving the proper direction. Okay. The right atrium is taking blood from the superior and inferior vena cava, of course, and so the superior is the upper portion, right, head, neck, upper limbs, etc. Inferior vena cava is receiving blood from the lower portion of the body, and the coronary sinus is the cardiac vein that essentially returns that blood and opens into the right atrium, which I think a lot of you saw in lab when you were looking at that. The foramen ovale is, before birth, is an opening through that interatrial septum that links those atria and essentially seals off at birth, allowing for them normal respiratory processes to take over. The right atrium, we're seeing pectinate muscles. These pectinate muscles, as I said, are different from what you see in the ventricle. They're sort of have ridges across them. They're not as powerful as we see, and they have a pretty distinctive appearance in terms of what they look like. And so you can sort of, if you look closely at this, you can see some of the pectinate muscle that's lining that inner portion of the atria. So the muscle itself is different than we see in the ventricles. In the ventricles, of course, we have trabeculae carnae, which is that trabeculae term you may remember from ANP1. We talked about trabeculae of spongy bone. Okay, and you can sort of see that sort of struts and plates in terms of how that muscle is organized. So it's very different from what you see at the pectinate muscle of the atrium. Okay, so that's what we're seeing in that structure. Again, a lot of this is anatomy stuff. Here's an actual sort of dissected aorta and other components of the heart that you can see. One thing also that's really evident, and an easy way to get oriented on the heart, is to look at the ventricle walls, right? Look at the left ventricle. Look how thick that is compared with the right ventricular wall. Much thinner, right? And a lot of that has to do with just the much more powerful on the left, because that blood has to travel through the aorta and up and out the entire body, right? Whereas this blood coming from the right ventricle is just traveling through the pulmonary trunk and going just to the lungs. And it'll go back this way as well. So the lungs would be basically, this is not drawn to scale, but the lungs would be there. So you don't need as powerful contraction. This has to go throughout the entire body. So this is a nice image, sectional anatomy of the heart, to sort of review and get a feel for. Right ventricle, important to understand chordae tendineae. We talked about that again. A lot of this is anatomy stuff. But these chordae tendineae, they attach to the papillary muscles, prevent the valve from opening backwards. It sort of locks it into place and, keeps blood in the ventricle and moving to the direction it needs to go instead of flowing back into the atria. So that's important. The right AV valve is also referred to as the tricuspid valve. And so it has three cusps. Again, the one from the left AV valve is called the mitral or bicuspid because it only has two valves. So make sure again that you're familiar with all that information. Trabeculae carnae are the muscular ridges on the internal surface of these ventricles. Talked about that just a minute ago, so you can see that. You can see some of the trabeculae carnae in this image here. You can see the papillary muscle and the chordae tendineae in these images as well. So those are good things to review. Let's see. The pulmonary circuit then, right, is going to send the pulmonary trunk is going to divide into the left and right pulmonary arteries, right? Even though it's deoxygenated, it's called an artery because it's going away from the heart. It's going to the lungs to acquire more blood. And so as blood flows from the right ventricle to the pulmonary trunk through that pulmonary valve, the pulmonary valve has three semilunar cusps, which again just direct the blood to the proper location. After the blood returns back to it goes to the lungs and acquires the oxygen, it's now oxygenated and returns to the heart in what's called the left atrium. And so it comes that way between the left and right pulmonary veins. Again, it's oxygenated, but it's referred to as a vein because veins always return blood back to the heart, right? And so it delivers the oxygenated blood via these pulmonary veins to the left atrium, left atrium then, of course, passes once. We'll talk more about the physiology of this, but ultimately it's going to push the blood from the left atrium to the left ventricle and goes through that bicuspid or mitral valve, which is the left AV valve, atrioventricular valve. Okay. Left ventricle can hold the same volume as the right, but it's larger, right? It's a thicker muscle, as we showed. It's more powerful and can contract and move blood throughout the entire body, right? That's the goal. And so the blood leaving the left ventricle passes through the aortic valve into the aorta, ascends up, and you'll see there are branches off of the ascending aorta, but then ultimately become the descending aorta to go then to the lower portion of the body. Okay, and so you can see that here. This is your aorta, right? And you have blood extending up, but then the descending aorta, it just continues on. So blood is going that way, but also continuing on to the lower portion of the body. Okay? So as I said, the right ventricle is thinner. It's going to have less pressure, therefore it's going to be less powerful. Right ventricle is pouch-shaped and is, left ventricle is rounder, and it's going to be more powerful. So here's a nice image sort of showing that. Here's the left and the right, really different in terms of their thickness and appearance. And there's another image showing it dilated, or when it's filling, right? The blood is filling into this space here, and it's filling into this space here. And look how small the opening is now during contraction, right? It squeezes that blood and pushes it out. All right, so the heart valves, right, that prevent backflow. We talked about the AV valves already. They're basically the pressure that fills during these contractions closes these cusps and prevents backflow, right? We talked about the papillary muscles in the chordae tendineae already, preventing these valves from opening. Semilunar valves, then, are pulmonary and aortic tricuspid valves that basically prevent backflow from the trunk and the aorta into the ventricles. So this one doesn't have the muscular support that we saw with the vascular, with the ventricles, but it has these three cusps, and you can see in this image right here, right? So here is the aortic valve, right, and here is the pulmonary valve. And here you can see the bicuspid and tricuspid valves and how they're really different, right, in terms of how they work. And so this shows sort of a nice cross-section through that component, right? And this shows how blood is moving into the left atrium, right? And as pressure builds in here, blood is going to fill into the left ventricle. The contraction of the atrium will polish it off and push the blood into the ventricle. You can see the chordae tendineae here, and ultimately the pressure will push and squeeze the blood out the aortic valve, which you can see there. Okay? And this again shows the valve now open, right? You can see that there as blood is moving. These guys are going to be closed, right? Because you don't want blood to go backflow through those AV valves. And now the aorta and the pulmonary valves are open. And then you can see the blood moving out as shown in this picture. Okay, as the ventricle squeezes and contracts. So make sure you look at that. All right, the coronary supply we definitely went over in lab. So this is pretty straightforward. It's just the blood that's supplying the heart, right? The heart is pumping blood to all the tissues in the body, but the heart also needs a source of blood supply and oxygen and nutrients. And so that is done through what's called the coronary circulation, right? It supplies blood and muscle to the tissues of the heart so that it can then continue and function properly, right? Lack of blood flow through this coronary circulation, right, is going to cause problems. Things like an MI, which we'll talk about in a minute, myocardial infarction could potentially happen. So I'm going to move through this. We already went over these arteries and veins. It's pretty straightforward in terms of how they're organized and where they're located. Okay? All right, so make sure you have a good understanding of the branches and how they're organized and where they begin in terms of the coronary arteries and coronary veins. All right, and this is a nice posterior view where you can see that. And there's another image. All right, so since we're talking about briefly just looking at the coronary circulation or the blood supply that's delivered to the heart itself, very obviously relevant clinical topic is coronary artery disease, right? Heart disease. It's the #1 cause of death still, even though we've made incredible progress with lifestyle changes and cholesterol medications and blood pressure medications and all kinds of things. People are living longer, but it's still the #1 cause of mortality. And so it's very significant, right? And so coronary artery disease is essentially CAD, or partial or complete blockage of this coronary circulation, where the blood is trying to be delivered to the heart so that it can continue to get its oxygen and nutrients that it needs. And so, like other tissues, cardiac muscle needs a steady, constant supply of oxygen and nutrients, or you're going to have issues, right? Reduction in blood flow to the heart is going to compromise performance, and if you have compromised performance, you could lead to coronary ischemia, which is where you have blockage and lack of oxygen being delivered to those locations. Okay, so this is a very nice illustration, just again showing we haven't really talked about vessels yet, but you can see oftentimes with vessels there is smooth muscle and arteries that are surrounding these vessels. And so if you take a cross section through it, you can see nice opening, right? Very easy for blood to pass through these locations. But what can happen is narrowing of an artery. Often that is the result of lipid deposits that can build up on the wall of these vessels, and they could ultimately return to plaque. Sometimes these plaques can diminish the amount of blood that can pass through, but also these plaques can rupture. So if this thing ruptures and causes a complete blockage, you can see how that would be problematic. And so can be very challenging, obviously, in terms of trying to deal with this and keep people healthy from coronary artery disease. So the typical cause or problem is fatty deposit, or this plaque on the wall of the vessel that I was saying. Oftentimes the plaque can cause a clot that narrows that passageways and diminishes blood flow. Now, as I said previously, there's smooth muscle around these arteries that's delivering oxygenated blood to the heart. And when their walls are disrupted, that smooth muscle can get irritated also. That smooth muscle can spasm, which can constrict and further diminish or decrease blood flow. And so angina is one of the very first symptoms of coronary artery disease, when you start to have temporary ischemia. And this is when the individual may start to feel, normal, okay at rest, but once they start doing something, exerting themselves, exercising, or stress, or other types of things, can get a sensation of, constriction or pain or pressure in the arm, in the chest, can go up the neck, and so forth. And that is angina that can cause that to happen. Now, if it's significant enough of a blockage, and you can have what's called a myocardial infarction. You guys have probably all heard of this, also referred to just as an MI, and that is where, because of its lack of oxygen, that tissue is not getting oxygen, the cardiac tissue is not getting oxygen, and those cardiac cells are dying off, basically. The death of that tissue then becomes non-functional, and we call that an infarct. Okay, and so that's why we call it a myocardial infarction. And so heart attacks typically result from coronary artery disease. If a blockage of a vessel delivering blood to the heart, heart muscle tissue is going to die off, depending on how much is impacted. That's going to be the severity of the disease. So myocardial infarction or impact, again, it's going to depend on where the blockage is occurring, but also the nature of the circulatory blockage, right? If it starts really high up on a branch, right, that could be very dangerous, because the higher up the blockage starts, the more areas are going to be impacted, right? If the blockage involves a really small branch, it may only impact a very small subset of the heart. So it really depends on where that blockage is occurring, okay? And so the plaque, as we said, can rupture. That can also happen, and this coronary thrombosis can be problematic from that standpoint. Pain doesn't always accompany a heart attack, but oftentimes does, and these MIs can be typically diagnosed with an EKG, which we'll talk about a little bit, or looking at the blood. That's another very interesting way. Oftentimes when myocardial tissue is damaged or destroyed, there are certain enzymes and components of the tissue that is released in the blood. So a higher level of certain enzymes in the blood that can be indicative of a heart attack. So certain tests you might look for, things like creatine phosphokinase, CK, is something that might be assessed because this creatinine is broken up and released into the bloodstream. Troponin can also be released and broken in the bloodstream. So if you use these blood tests to analyze these components, it may be indicative of a heart attack. Okay, 25% of MI patients die before they get medical assistance, and 65% of those occur pretty soon after that initial infarction. So it's important to get care as quickly as possible. Now, in terms of things that can be done in terms of modification, I think all of you are probably well aware of things like stop smoking, exercise, eating a healthier diet, reducing your stress. All these things are going to be, positive factors for helping someone reverse, or prevent myocardial infarction from occurring. In addition to those lifestyle modifications, drug treatment is another option, something that can happen very, is pretty common in terms of treating. So one thing, for instance, is drugs that can reduce coagulation, so minimize the ability of your blood to clot. And so like aspirin, some people just take like half a baby aspirin a day as sort of an anticoagulant, or Coumadin is a more severe, not severe isn't the right word, but more extreme version of a blood thinner that tries to reduce the risk of some sort of blockage or thrombosis occurring. There are drugs that can block sympathetic stimulation, right? That's going to depress heart rate a little bit. Drugs that can cause vasodilation, like nitroglycerin, right? That's going to cause vessels to dilate instead of constrict, which could help allow more blood flow to move through the body, or through the heart, excuse me. Certain calcium channel blockers might also impact the heart, or vascular smooth muscle cells, right, to keep that smooth muscle from constricting. And so all those things are involved in drug treatment. There are some surgery options where you can have a catheter placed into the plaque. Angioplasty, you may have heard of that. The catheter typically contains an inflatable balloon that basically opens up and has like a sheath in the place to try to keep that artery open to allow blood to continue to move through that area. Bypass grafting is another thing, right, where you actually remove the clotted or clogged section of the artery and replace it with another type of artery, right? So you're sort of rerouting. So if you've heard of someone that has like triple bypass or quadruple bypass, that's the number of arteries they had to bypass that were clogged so severely that they actually had to cut them out and replace them and reroute the location. Okay, and so here you can see a nice image of what happens when you get blood flow to a normal heart versus what happens to the heart in diminished blood flow, and how dangerous that can be. Here's a nice image of sort of how this works, right? You have your occluded coronary artery. The blood cannot get through. It's stopped right there. And then so all these areas over here is where you're going to have the infarct, wherever the blockage occurs, right? So the higher up, right, and the larger the vessel, the more dangerous it's going to be. If the blockage is way down here, let's say, for instance, right, can you see how it's probably only going to impact this area as opposed to a much larger area if the blockage is up higher. So we were talking about that before in terms of blood flow. All right, so that sort of wraps up the anatomy stuff as well as the blockages and coronary artery system and things like that. And so now we want to start moving more towards the physiology. Again, it's really important to have a strong understanding of the anatomy and how this thing is organized, because that's going to help you make sense of it as we start looking at the physiology. And so that's what we want to do right now, is look at the physiology. And so the heartbeat, of course, is a single contraction of the heart. Starts with the atria, that contract first, of course, and then the ventricles. And so we want to look at not only what regulates and controls heartbeat, which is a conducting system, but also the contractile cells themselves and actually how they move things through. So there's really two things. There's a conducting pathway that's going to regulate the heartbeat and move the impulses from the nervous system through the heart. But then there's the contractile cells that are actually going to do the pumping and the contracting of the muscle. Okay, so that's what we want to look at. So cardiac cycle, which is sort of how we're going to talk about it, which is basically one heartbeat. We're going to look at it from beginning at what's called the SA node, or the sinoatrial node, that'll move through this conducting system and work its way down to the actual cardiac muscle cells, where the contraction will then occur. Okay, the movement of these impulses through the depolarization and then ultimately repolarization of these muscle cells are the electrical events that are occurring. And as you probably know, you can record these electrical events, right? The depolarization occurs and repolarization occurs. You can see these images on a graph in what's called an electrocardiogram. Okay, and so that's a way to, ECG or EKG, a way of looking at these things. So the conducting system are these specialized cardiac muscle cells that basically initiate and move the impulse through the muscle so that it contracts. And the cardiac muscle tissue is going to respond to those impulses by contracting automatically. And the significant components of the conducting system, again, we have the SA node, which I mentioned, the AV node, and then ultimately the conducting cells. Okay, so if we look at this image right here, okay, you're seeing the passageway. Right here is the SA node, here is the AV node. Okay, we have what are called bundle branches. Okay, ultimately then Purkinje fibers, and as these impulses move or are conducted through these pathways, through this conducting system, correspondingly, these muscles are going to respond to that and contract. Okay, so that's what we want to look at as we sort of go through this. All right, so the SA nodes and the AV nodes are interconnected and distribute that initial stimulus that arrives through the myocardium down into the ventricles via the bundle branches. Okay, the pre-potential, also called the pacemaker, is ultimately the result of the initial depolarization at the SA node. So the SA node is really where it kicks off, and that is what is establishing heart rate. If the impulses are arriving faster at the SA node, the heart rate's going to go up. If they're arriving slower at the SA node, they're going to go down. And so it's basically dictated by what's happening at that site. So the SA node is very important, which you can see in this image right here. Okay. All right, so this again shows the depolarization that's occurring as you depolarize, starting at threshold, and then repolarize back into, back to normal resting potential. Okay, so the heart rate is stimulated by the sympathetic division, right, and the parasympathetic stimulation is what's going to slow heart rate. So we'll talk a little bit about that. So the SA node is in that wall of the right atrium and essentially begins with atrial activation, which is the first step. So SA node activity begins, and that is ultimately going to send impulses traveling down through that atria. Okay, stimulus spreads across the atria and reaches the surfaces of the AV node. So as this moves through, it's going to work its way down to the AV node. So as this impulse travels over the atria, ultimately the atria then will contract. And so as you saw in that previous picture, right, the move down, we're going to see contraction of this component. Now the AV node will be activated and continue on through the bundle branches. Okay. Impulse travels down the bundle branches, all the way down to what's called the Purkinje fibers. Purkinje fibers will then send the impulse ultimately out into the ventricle, and then the ventricle then will contract in response to the depolarization that's going over there. So it should make sense to you then that as these waves move, you can see why the atria contract before the ventricles contract, right? Because the impulse is beginning up at the atria, right? And so as the depolarization wave moves through the atria, in response to that depolarization wave, right, the atria will contract, but it still takes time for it to then move down the Purkinje fiber, or excuse me, the bundle branches and the Purkinje fibers before then the ventricle will contract. Okay, so that's important to understand. This heart rate is a very highly coordinated and synchronized event, and you can see why it is, because of this coordinated flow of the impulse moving from the SA node all the way down the AV bundles, ultimately to the Purkinje fibers. And so that's why you have that flow of contraction. Now, you can have, abnormal pacemaker function when, if, for instance, bradycardia or tachycardia, which is either too slow or too fast of a heart rate. You could have an ectopic pacemaker, which is essentially going to bypass this conducting system and really going to impact ventricular contractions, which could be very dangerous. So those are all things sort of to consider along with that. But again, looking at this wave of depolarization, we can analyze this in what's called an EKG. So it's a recording of these electrical events that are happening in the heart. So if you put electrodes around the body, in very specific locations around the heart, and then like in your arms and legs, you're going to get a reading that can show what, typically normal heart rate depolarization and repolarization patterns need to be, but then we can also recognize abnormal patterns that may diagnose some sort of problem or damage or issue based on looking at the EKG. So it's a nice non-invasive way for a cardiologist, for instance, or clinician to get an idea of what's happening at the heart. Okay, and so there are different features on an EKG that I want to make sure you have a good understanding of. Things like the P wave or the QRS complex. These are all features that are significant because they're reflecting what's happening at the given time of the cardiac cycle. So for instance, the P wave is showing the depolarization of the atria, right? And so that's the first thing you see, which makes sense, right? Because the atria is what we're, from the SA node impulse, that's what's going to depolarize first. And so that's the first thing you see in a EKG reading, is the P wave typically. After that, when you get depolarization of the ventricles, you get the big QRS complex. And so the P wave will look something like this, right? And then the QRS complex typically looks something like this, right? And then finally, the last thing you see is a little bump called the T wave, which is the repolarization of the ventricles. And then the cycle will then start over again. But that's sort of what you're seeing in the P wave. Here, I'll try to put a little P there. All right, this is what's called the QRS complex. And then the T wave is over here. All right? So that's kind of what you're seeing as you sort of work through these images. There also are intervals, right? There's a certain amount of time that these things are supposed to take. And so, for instance, the PR interval is significant because that's the beginning of atrial depolarization to the beginning of the QRS complex. And if you have a delay there, right, it may throw off the whole system. So that's another thing cardiologists can do, is just look at certain intervals. And they're supposed to be a set length. If they're not a set length, you're going to have issues, right? And so QT interval is another one. From ventricular depolarization to the repolarization of the ventricles is another thing you can look at. So anyway, so here's a nice image of, what the setting up of these electrodes and placement of these electrodes. Some of you may have had one of these before. Hopefully in the lab we can do a sort of a simplified version of an EKG so you can get a feel for how this works in this EKG reading. All right. So this is a really important slide. This is what you want to understand in terms of not only for lecture but for lab, in terms of the waves and the significance of the waves, and how long they're supposed to be, the PR interval, QRS complex, etc. So make sure you have a good understanding of that in terms of what's going on with each of these components. All right. Now, there are many abnormalities to EKGs that you can look at, things like atrial fibrillation or premature atrial contractions or premature ventricular contractions, right? These are all different components that you can see on an EKG that might be abnormal and potentially cause problems, okay? So take a look at those, and we'll talk a little bit more of those when we do EKG. Now, the conducting system also, we have the electrical component, which we just talked about, but then you also have contractile cells, right? The Purkinje fibers distribute that stimulus into those muscle cells, and that's where you see the cardiac muscle is going to contract. Typically, the resting potential of the ventricles is about -90, whereas that of the atrium is typically about -80 millivolts. Okay, so the contraction of the cardiac muscle cells is produced by calcium ion concentrations, right? So calcium, as we know, is playing a significant role, allowing for these interaction of these thick and thin filaments. Calcium ions enter, excuse me, the membrane. Extracellular calcium then causes a release from the sarcoplasmic reticulum that's going to allow for the formation of these cross bridges and allow for contraction to occur. Okay. Ultimately, as the calcium channels close, that calcium can be reabsorbed by the sarcoplasmic reticulum, and as a result, this cardiac muscle is very sensitive to these concentrations found in the system. So this is not unlike what we talked about in ANP1 with skeletal muscle. Very similar in terms of the role of calcium and the importance of calcium. So we want to make sure you have a good understanding of how that works. The energy for these cardiac contractions, typically fatty acids and sugar, are the things that are primarily going to be responsible. The cardiac muscle can store a little bit of oxygen in this myoglobin, but it needs an energy source. And it gets that from, the mitochondria, which are obviously using fat and glucose to form these, energy sources in the heart. All right, so the cardiac cycle then, which we're going to look at specifically in terms of the contraction of the heart, is a period from the beginning of the heartbeat to the next. And so the thing about the heart that's really important is contraction, obviously, but also relaxation, because relaxation needs to happen to allow for additional filling to occur, right, for the blood to then refill back into the compartment where it was contracted from. So contraction and relaxation, we're going to look at both of those, and it's really important to have a good understanding of that and how it works. So two phases of the cardiac cycle are systole and diastole. You've probably heard of these terms because that's what your blood pressure reading is, right? Blood pressure is like 120 over 80. This thing is not writing that well. Don't know why. 120 over 80, right? The 120 is the amount of pressure during systole, right, or contraction. Systole is another term for the contraction of the heart. And the 80 is the pressure in the vessels during diastole or relaxation. So the systolic over diastolic is maybe where you've heard that before from in terms of contraction and relaxation. Okay, so that's systole and diastole. Those are terms you definitely want to get familiar with as we're going to talk about the importance of contraction, but also the importance of relaxation. And so if you look at this chart, this is really nice because it shows really the whole cycle in terms of the beginning of atrial systole, which is atrial contraction, of course, and what's happening throughout these processes. And so I'm going to go into detail and talk about this slide. So the first thing that happens during this phase of cardiac cycle is atrial systole begins, right? Systole is contraction, right? So the atria squeeze and contract and push blood into a relaxed ventricle, right? So this is where you're having the most amount of space and filling time that's going to occur in atrial systole, okay? At the end of atrial systole, okay, then atrial diastole begins, right? Relaxation of the atria, which is really important, right? And so it needs to relax so that more blood can then fill into that chamber, right? So it's very important to have not only contraction, but to have relaxation. So atrial systole ends, atrial diastole begins, okay? After diastole, right, or excuse me, after systole, of course, then now we have ventricular systole, right? Ventricular systole has a couple different phases that we're going to talk about, but essentially the first phase is when the ventricle contracts and pushes pressure so that these guys close, the AV valves close, right? And so, but at this point, it's not created enough pressure to open the semilunar valve. So this slide is actually a little bit premature. It's not gone through there. The first part just makes sure these are closed, and then the increasing pressure will push the blood through that semilunar valve. Okay, so the second phase of ventricular systole, which this picture is more accurate now, is showing the pressure going up and exceeding the amount of pressure in these arteries. The semilunar valves open, and the blood is ejected. Okay, so that's the second phase of ventricular systole. After the end of ventricular systole, of course, now comes ventricular diastole, which is relaxation, right? And as the ventricles relax, the pressure in the ventricles starts to drop, right? Blood flows back against the cups. These valves close, right? And blood continues, as we talked about before, to flow into the relaxed atria. Okay, now in late diastole, right, we're going to start to see, because all this time blood has been filling into the atria, we see what's called passive filling of the ventricle, right? Because these guys are relaxed and there's more pressure here, you're going to see blood move into the ventricle. Okay, and so that is late diastole, right, where you get some passive filling of the ventricles. All right, so that's really just in a nutshell what happens in the cardiac cycle. Okay, and so whenever you have systole, the amount of pressure in that given chamber is going to go up, right? Because the muscle's contracting, there's going to be more pressure, and during relaxation, pressure is going to go down. Excuse me. And so blood flows from an area of high pressure to an area of low pressure, right? And so these contractions are synchronized to make sure that the blood moves to the appropriate locations, but also that these valves dictate that and control it. Now, for our purposes in our discussion, we're going to say, that cardiac cycle or heart rate is typically about 75 beats per minute. So cardiac cycle is going to last about 800 milliseconds to get that. When heart rate goes up, everything in the cardiac cycle is going to shorten, particularly diastole. So you get less relaxation time as these heart rate levels go up. All right, so understanding generally how this system works, now we can sort of look specifically at each of these components and talk a little bit more about exactly how they work. So I want to make sure you have a good understanding of the phases specifically within all of these components. Okay, so we're going to look specifically at atrial systole, see exactly what happens, move on to atrial diastole, et cetera, and see exactly what happens. We have a stronger feel for what's going on. All right, so the first thing is atrial systole, of course. This is when the atria are contracting. So during atrial systole, of course, atrial contraction begins, and those right and left AV valves are open, right? We already said they were open because they were passively filling. So once the atria contract, right, they're going to eject the rest of the blood into the ventricles, and that's going to fill the ventricles, right? When atrial systole ends, the AV valves close, and at this point, when the end of atrial systole, the ventricles now have the most blood they're ever going to get, because they're not getting it anywhere else. Once those AV valves are closed, there's no more room for the blood to enter that location. So at that point, we have what's called end diastolic volume, EDV, end diastolic volume. And that's when the heart, the ventricle, has the most blood it can possibly have. So EDV is really important from that standpoint. All right, so after that, we then have ventricular systole, right? The ventricles will begin to contract, and as they contract, they're building pressure inside that chamber, okay? And so this initial pressure, as we know, causes the AV valves, once they're closed, you get what's called isovolumetric contraction, right? Because the ventricles are contracting, right? But the volume inside the ventricle is staying the same. So we call it iso, same, volumetric contraction, right? Because nothing has moved yet. You're just building pressure inside that ventricle. Okay? So as the pressure and the contraction continues to increase, then we get what's called ventricular ejection, right? And that is when the ventricle pressure exceeds the vessel pressure and the semilunar valves open and the blood then leaves the ventricle. Okay? And so whatever is ejected in that contraction of the ventricles, right, that leaves the ventricle, is called stroke volume, or SV. Okay? And so stroke volume is ultimately the determinant of how efficient the heart is. Okay? Now, at the end of ventricular systole, because all the blood has been pumped out, the amount of pressure in that ventricle is starting to go down. So the semilunar valves close, and at this point, there's ESV, or end systolic volume, right? And that's how much blood is left after the contraction. So we had end diastolic volume, which is the most amount of blood, and systolic volume, which is the least amount of blood. So it's about 40% of EDV in terms of what is remaining. Okay, so that's ventricular systole. Now, this image is nice because it shows what's happening in these processes. Okay, and so you have, sort of looks like a very busy chart, but actually it's not too bad. Up here you're seeing what's happening at the atria. Here you're seeing what's happening in the ventricles in terms of contraction or relaxation. Here is how much pressure is in those components, and then this is the amount of blood volume in those components. So first thing, during ventricular diastole, right, you can see that the amount of pressure in the ventricle is pretty low, right? Because it's during relaxation, right? Diastole means relaxation, so your pressure is pretty low, okay? But as the ventricular starts to contract, look what happens to the pressure. It goes way up, right? Pressure goes way up because of the amount of blood. But look at the blood volume. As pressure goes up, right, the blood is being pumped out. And so that's showing you how much blood is being released in this process. So this is more of a visual sort of how this process works in this cardiac cycle. Now, at ventricular diastole, ventricular pressure is higher than the atrial pressures. All the hearts close, and you get what's called isovolumetric relaxation, because the ventricles are relaxed, the volume is the same, and so at this point, the atrial pressure is now higher than the ventricular pressure. The valves open, and that's where you get that passive atrial filling, but also you get passive ventricular filling, right? Because there's less pressure now in the ventricles as the atria is filling with blood. Okay? So that's an important concept to understand in terms of ventricular diastole. So as you can see, the contraction, of course, is really important because contraction builds pressure and pushes the blood from one place to the next. But relaxation, or diastole, is also really important because that allows it to refill. As it refills, it builds more pressure, and that's going to make the whole cycle work. Okay. So in this slide, we're seeing sort of the end of ventricular systole, right? And so the pressure now as the blood leaves is going down, right, until the end of systole. And then finally, ventricular diastole, we're going to start to see filling during relaxation. We start to see filling, right, as you're in relaxation, right, diastole. Okay, so make sure you go through this chart. It's sort of a visual way of looking at the processes of this cardiac cycle, all right? All right, so here's another image of those things together, where again you can also see the lub-dub. I was talking about this in class a little bit with the AV valves closing and opening, the semilunar valves closing and opening. That's where you're getting those sounds that are occurring that you hear from the heart rate. Is actually the opening of those valves, opening and closing of those valves. All right, so important thing to understand then about heart and how it works is a thing called cardiodynamics. Okay, cardiodynamics is basically using a lot of these terms to understand, how much blood is being actually moved around throughout the body. And so, end diastolic volume and systolic volume, stroke volume, those are things we all talked about. And so we want to take a little bit closer look and see how those things the significance of those things. So stroke volume, right, that's the amount of blood that's pushed in a ventricular contraction, is equal to the end diastolic volume, right, which is the most you're going to have, right, and minus end systolic volume, right? So that's how much you actually pump out, right? And so the ejection fraction then is the percentage of end diastolic volume represented by stroke volume, right, where you get how much you get pumped out that's left in that chamber, right? And so another way to sort of thinking about this is looking at the heart as like a bike pump, right, where you have a filling time where you pull things in, and that's equivalent to ventricular diastole, but then of course you have a pumping time where you push things out, and that's equivalent to ventricular systole. So it's important to understand that you have these two components at work, filling and relaxation, in terms of you know, how the heart actually pumps and works. And so you may want to use this example of, you know, sort of a pump handle as in terms of how the heart works, and that's really what it is. It's a pump. And so if you look at these slides, when the pump handle is raised, like think of a bike pump. This is, I think, sort of showing water, but bike pump's sort of the same way, right? You have to get some air in the chamber before you can push it down, and that's equivalent to the filling that occurs, right? Like during ventricular diastole, when the ventricles are relaxed, right, you're going to get filling, and so that's what that is. Filling, so you get something actually to pump through the system, okay? Then that time when you get all the blood you're possibly going to get into that pump, when you're at the height of pulling your bike pump up, right, that's end diastolic volume. That's the most you're going to have in there at any given time, right? And so that's EDV, end diastolic volume. And then the pumping is when you get ventricular systole. When you push the handle down, it pushes the blood out, right? That's ventricular systole. And at the end of the pumping process, whatever is left, right, you're not going to get every last bit of air out of that canister. Whatever is left, that's ESV, end systolic volume. At the end of systole, how much do you have left, right? And the difference between EDV and ESV then is stroke volume. Right? That's how much was pumped. That's what stroke volume represents. Okay, so this may be an easier way for you to sort of learn this and remember it by looking at this sort of bike pump handle. Now, we understand what those things are. A really important thing to understand is what's called cardiac output. Cardiac output is a measurement that looks at how much blood is being pumped by the left ventricle to the body in 1 minute. So it's not looking at each pump. It wants to see, okay, what's happening in a full minute, because that gives you a more reasonable number to work with. And so stroke volume is how much blood is being pumped by the ventricle each heartbeat, right? So to get a minute, you just need to factor in heart rate. So you take stroke volume, which is what happens with each pump, right? That's EDV minus ESV, and multiply that stroke volume by the heart rate, right? And so that gives you the cardiac output. It's a very common measure in cardiology and diagnostics is milliliters per minute. How much is the heart pumping out? And so the heart rate, of course, is beats per minute, and the stroke volume is how much blood is being pumped each heartbeat. Okay, so make sure you understand how you can calculate cardiac output. Yeah, well, how can you alter cardiac output, right? Your cardiac output is not always going to be exactly the same. Your body's going to need more blood or less blood, and so it has to adjust that, right? And so cardiac output is adjusted by changes in either heart rate or stroke volume, because that's what makes heart rate up, right? So one way to adjust cardiac output is to increase heart rate, have more autonomic nervous system hormones from the sympathetic division firing at that site. Your heart rate's going to go up. You're going to increase cardiac output because you're doing it more often, right? Or stroke volume can change, right? Or it may be a combination of both, right? If you change the amount of blood that's pumped out or that fills, right, that could change the stroke volume. So either stroke volume or heart rate or both can alter cardiac output, right? And so you can see that right here. Factors affecting heart rate, autonomic innervation, hormones, right, are going to drive heart rate up or down. Stroke volume, changes in EDV or ESV are going to alter stroke volume. One of those two things is the only way you can change cardiac output. Okay, so that's something to consider. Now, in terms of cardiodynamics, just sort of as a review, we talked about this back in AMP1, but this is regulated by the autonomic nervous system, right? The ANS. You guys know that, right? You don't consciously regulate how many heartbeats are occurring in your heart in a minute, or that it has to adjust when you start exercising, right? That's done on its own. And it's done through this vagus nerve carrying parasympathetic fibers, and these cardiac centers in the medulla then are acceleratory center, right, increasing heart rate, and inhibitory center slowing heart rate, right? And so these are the areas that are working. As we talked about last time, autonomic tone is where you get both acetylcholine and norepinephrine being released at the same time to give you sort of a background level of activity, and you can either go up or down from that component. Okay, and so this just sort of shows, sympathetic and parasympathetic, right, sort of regulating that. The vagus nerve is responsible for that, and how its innervation is coming down to the heart and sort of driving that. All right, so let's just sort of review from that standpoint. But you guys recall from AMP1 that the heart does have both sympathetic and parasympathetic input. All right, so membrane potential of pacemaker cells is lower than other cardiac cells, as we talked about. Spontaneous depolarization obviously is going to be impacted by what that resting potential is, but also how much depolarization is happening. What is the rate of depolarization that's occurring at that site, right? And so I would say just sort of review this briefly, but again, this is just sort of showing depolarization, reaching threshold, repolarization, sort of that process of the pacemaker cells. And you can sort of get a feel for how this depolarization is occurring. So as we said, right, sympathetic and parasympathetic stimulation are driving heart rate. And so if you have an increase of acetylcholine from the parasympathetic site, heart rate's going to go down. Increase in norepinephrine from the sympathetic site, heart rate's going to go up. Okay, and that sort of shows what's happening in that location. Via parasympathetic, right, you're getting slower number of beats. Sympathetic stimulation is increasing things, increasing the depolarization rate. All right. Let's see. There is an atrial reflex, also referred to as the Bainbridge reflex, which can adjust heart rate in response to venous return. So as the blood is pumping back to the heart, right, the atria is going to stretch more, and that can trigger increase in activity, right? And so we talked about these hormones already, and the hormonal effects on these components. So the factors that are ultimately going to affect stroke volume, the end diastolic volume, right, as we know, it depends on filling time, but also how much blood is returning back after that process. So preload then is the, how much stretching that's actually occurring during diastole, right? And it impacts the ability of the muscle to then ultimately produce tension. Okay, and so the end diastolic volume and stroke volume at rest, EDV is very low, right? You're not getting as much stress because not as much blood is returning back to the heart. So stroke volume is very low. But as exercise increases, right, your end diastolic volume is increasing because the more blood is returning back to the heart. So the myocardium stretches more, you get more stretch, more fill, stroke volume is going to increase. So as I said, when you have not only heart rate is going to increase cardiac output, but stroke volume can change as well with exercise. Okay? And so the Frank-Starling principle then is that as end diastolic volume increases, right, when you have more blood in that chamber at the end of diastole, then of course stroke volume is going to go up, right? There is some limitation based on, how much filling can happen. It's not like you can just fill, till it gets incredibly large or something, but it's going to be limited somewhat, but you get the point. You can have a change in EDV. So that's what this Frank-Starling principle is that as end diastolic volume increases or changes, right, you're going to see a corresponding change in stroke volume. Okay, so end systolic volume amount of blood that remains in the ventricle at the end of ventricular systole, we know that. I'm not sure why that slide is there. Oh, okay, so that's just saying what were the three factors that can impact then end systolic volume: preload, contractility, and afterload. I don't think that's as important in some of these concepts that we've looked at today. We really already talked about effects of autonomic activity on contractility, so let's kind of review. So we really went over these parts already. The hormones, of course, impacted. And then so this just looks at factors affecting stroke volume. You can look at that as well. All right, so that is it. So I think that should get you covered on all the information there with the heart. Again, focus on the things that I focused the most time on. I didn't spend as much time on the anatomy as we went over it more in lab, but again, it's really important to have an understanding of the anatomy so that you can make sense of the physiology. So anyway, so that's it. I will post the next lecture here coming up early next week, and that will be on the vessels, which is the third component of this cardiovascular system. All right?